Welcome, everybody. Thank you for being at our CIPC, our Center for Improving Palliative Care. And I'm very excited about our enrichment program today. This is Palliative Care-Related Knowledge, Attitudes, and Confidence in Home Health Care. That's PKAC. And it's a review of the literature and the development of an instrument. And I think this is going to be interactive. They want some feedback. The presenters are some really good collaborators and colleagues. So it's really my pleasure to present Jingjing Shang. She's a professor here in the School of Nursing. She graduated Johns Hopkins and then did her postdoc at Penn and has been a collaborator here for, I don't know how long, probably 15 years or so. That's what I guess off the top of my head. And then another presenter is Komal Murali. She is one of our CER2 postdocs. She's in the second year of her postdoc. She's a graduate, got her PhD at NYU, and is very interested in palliative care and adults with multiple chronic conditions, and we're very excited to have her present and be a part of the team. And then last but certainly not least is Ashley Chastain. She is one of our senior project directors. She has her doctorate of public health from CUNY. She's been working with our teams for over 6 years, and so it's really a good collaborator and co-investigator. So thank you all for presenting, and please take it from here.
Okay, thank you, Pat, for this introduction. And I'm very happy here today. I'm going to work with my colleagues to present the preliminary finding from our pilot project. So next slide, please. So first, I will give a brief introduction of the background, and then we'll hand into Komal and Ashley. We can talk about the work we have done and the instrument we are developing right now. Okay, next slide, please. So we all know the palliative care provides the patient and family-centered care to patients or individuals with serious illness. And the home health care is a booming industry in the US. Every year, there's about 3.4 million Medicare beneficiaries receive home health care. And the majority of the home health care patients have multiple chronic conditions. This figure shows like over 80% of home health care patients have more than 3 chronic condition, and we see that like over 40% of home health care patients have more than 5 chronic conditions. And another study conducted in 2020 found that 19% of home health care patients died within a year after their home health care admission. Next slide, please. So clearly there's a rising need for palliative care in the home health care because of the complex the condition. However, there is no currently there's no community-based palliative care benefit in the Medicare in the fee-for-service Medicare, and most recently CMS has have some like ongoing palliative care in the home health care demonstration project, and we all know the home health care services delivered by the agencies is a lot overlap with the palliative care because they have a lot of symptom management, a lot of care planning. In last October, in the National Conference of NAC, National Association of Home Health Care and Hospice, the leader pushed for the home health for the palliative care delivery in the home health care the setting. However, before a large scale of palliative care delivery in the home health care setting, we don't know whether the home health care clinicians are prepared to deliver this service, and we also not know if the home health care patient and their caregivers they perceive the palliative care. So that is the reason why we conduct this pilot study. Next slide, please. So this pilot has two aims. First, develop the two instruments we call the palliative care related knowledge, attitude, and confidence in home health care. And one is for the home health care clinician, another one is for the patient and informal caregiver. And we also want to test these two instruments and evaluate the psychometric property. Next slide, please. So I'm going to hand it over to Komal. She's going to describe the first work we have done, the literature review.
Thanks, Dr. Shang. Next slide, please. So our systematic review evaluated the current evidence surrounding the measurement of palliative care-related knowledge, attitudes, and confidence in home healthcare clinicians, patients, and caregivers. This topic required further exploration before we embarked on this study, because as palliative care services increase in availability in home healthcare, it's really unclear if patients, clinicians, patients, and caregivers have the necessary comprehensive palliative care-related knowledge to effectively deliver, utilize, and understand services. And while there have been instruments created to measure palliative care related to knowledge and attitudes in other settings, none from our review were found that were specific to home health care in the existing literature. So the goal of the National Consensus Project for Quality Palliative Care was developed to improve access to quality palliative care for seriously ill individuals across settings, and it provides specific guidance for healthcare organizations and clinicians to integrate best practices to deliver high quality care. There are 8 domains of palliative care that this encompasses, including structures and processes of care, physical, psychological, or psychiatric, social, spiritual, religious, and existential, cultural, end-of-life, and ethical or legal aspects of care. We've reviewed the literature to assess existing instruments that measure palliative care-related knowledge, attitudes, and confidence, and specifically in home health care, clinicians, patients, and caregivers. And we also use these 8 domains of palliative care as conceptual guidelines to appraise the completeness of existing instruments and highlight any gaps in the evidence related to these domains. Next slide. Next slide, sorry. So our literature search looked at PubMed, CINAHL, Web of Science, and the Cochrane database for systematic reviews for articles between 2000 and 2021 that reported on studies measuring palliative care-related knowledge, attitudes, and confidence in home health care. And the key search terms and Boolean logic that were used in our database searching are provided here. The 2 searches presented were conducted individually in each database and respectively conducted and reviewed by 2 study investigators independently and then reconciled. Next slide. Our inclusion criteria were developed to ensure that the articles chosen were specifically focused on home health care, focused on knowledge, attitudes, or confidence, and it had must be related to palliative care. And then it reported on any existing measurements, scales, instruments, or questionnaires that were measuring this knowledge in clinicians, patients, or caregivers. Next slide. After screening abstracts, 41 articles were selected for full text review, and 2 different investigators independently conducted this screening. After the inclusion and exclusion criteria were applied, we had 17 articles included in our final review. 2 investigators completed quality appraisal of each article using the Crow Critical Appraisal tool, and the contents of all the final articles provided substantive discourse related to palliative care, knowledge, attitudes, and confidence in home health care. And many of these articles did include instruments or questionnaire items that could be used for our study in future instrument development. Each research article was assigned a score of 0 to 40, with higher scores indicating higher quality, and any discrepancies in the scoring were discussed and disagreements were settled accordingly. All the quality appraisal scores that we came up with ranged between 30 and 40, and the selection of articles was agreed upon by all investigators in the study. Next slide. 17 articles met our inclusion criteria, and the findings represent over 9,000 clinicians, patients, and caregivers, 1,700 patients and 279 caregivers. And studies were conducted across 10 countries, and all were focused on home healthcare or home care clinicians, patients, and caregivers. And the majority of studies did include instruments that were investigator initiative, conducted cross-sectionally, or instruments or questionnaires that were derived from existing instruments. Examples include the Frommold attitude toward dying of the care or palliative care difficulty scale and palliative care knowledge scale. Physicians, home care nurses, social workers, care managers, administrators, and nursing students were among clinicians and healthcare workers represented in the study. But most notable from our review was that none of the studies included home health aides or equivalently titled individuals who provide most hands-on care, as we know here in the United States, which is a vitally integral part of our home healthcare workforce. Next slide. So there were varying degrees of knowledgeability among home healthcare clinicians across studies. Many clinicians understood the reason for palliative care delivery, but there was varying degrees of knowledge about specific palliative care related delivery, such as pain and symptom management, and inconsistent knowledge about educating patients and caregivers about hospice and the difference between hospice and palliative care and when the transition to hospice was appropriate. Many clinicians were aware of the psychosocial benefits of palliative care, but it was inconsistent across disciplines. Regarding attitudes, most home healthcare clinicians had favorable attitudes about providing end-of-life care and palliative care and were supportive of the idea of death and dying in the home. However, work engagement and adequate training were linked to more favorable attitudes. And many felt that they played a key role in reducing suffering at the end of life, specifically related to pain management. And attitudes about the roles of home healthcare clinicians were mixed because there was a lot of confusion surrounding role clarification, specifically which home healthcare clinicians were responsible for providing palliative care. And confidence was measured in the context of education, competency, preparation, and prior experiences with palliative care, which were varied among clinicians. And notably, with those with higher levels of confidence had more experience in home health care. Next slide. So patients and caregivers had low to moderate levels of general knowledge and awareness of palliative care. And we know that this is consistent with the existing literature. There is also inconsistent or incorrect knowledge about opioids and pain management specifically, and most believed that palliative care was only suitable for end-of-life care. Attitudes about palliative care were variable, specifically surrounding the use of palliative care and how individuals perceived receiving palliative care in the home. And there was also a great concern among many patients and caregivers about placing undue burden on other caregivers in the home if palliative care were involved, and there was a specific focus on death and dying. Attitudes about honoring patients' wishes and preferences were favorable, and many preferred regular communication about diagnosis and disease progression. Confidence was actually not measured in any home healthcare patients or caregivers across studies. Next slide. So the main takeaways from this review are that while existing instruments measuring knowledge and attitudes exist, none were available that were comprehensive, including all 8 domains of palliative care, and none included home health aides, personal care aides, and other paid caregivers in their samples. And not surprisingly, there was significant variation across countries and healthcare systems in terms of measurement and approach. Next slide. So in conclusion, a comprehensive NCP domain guided instrument for measuring palliative care knowledge, attitudes, and confidence in home healthcare is needed. And this is important as we proceed with any sort of implementation efforts. Identifying gaps in knowledge and understanding attitudes and confidence in this population and key stakeholders is really important as we try to guide training and education in the context of growing palliative care services in the home. So now I'll hand it over to Dr. Chastain, who's going to talk about where we are with instrument development. Thank you.
Thank you, Komal. So yes, I'll talk about how we developed our instruments. So after you can advance the slide, I'm sorry. Sorry, Bridget. So after we conducted our literature review, we also searched for any gray literature on the subject as well. And through that process, we amassed a list of several existing instruments that had been used in various settings. And while we had inclusion and exclusion criteria in our literature review, we also went through an appraisal at what would be step 2 here on the slide to determine if the instruments met the criteria that we were looking for in our PC KAC in home healthcare instruments for clinicians and patients and caregivers. And we put the existing instruments into a spreadsheet, and all 7 of our team members rated whether each item within each instrument should be included or not. And we tried to keep instruments together, of course. And whether we should make any modifications for a US audience, as many of the instruments that we found were developed for use in other countries. And we also indicated whether we should make modifications for the home healthcare setting. Next slide, please. Our third step was to align the instruments that we had chosen in the appraisal step to the 8 domains of practice from the NCP guidelines that Dr. Murali had talked about. And next slide, please. And from that alignment with the 8 domains, we could see where we had gaps. And for example, there were little to no questions that we found in existing instruments on ethical and legal aspects of palliative care for either clinicians or patients or caregivers. So in that case, we generated new questions as a group to address that domain within our instruments. And we also adapted some of the items for the US home healthcare setting at this stage. And our final step was consultation with our expert panel, which was made up of 5 members with expertise in various aspects of palliative care. And some of them are actually on this call. We have Joan Casano with us and June Stanley. So we thank them for their input. And after receiving their feedback, we went through again. We went through a few rounds of refinement and reduction of items as a group. So next slide, please. And our PCKIC instruments, the final ones, are organized by 3 main sections. So the knowledge, attitudes, and confidence. And each section contains items relating to the NCP guidelines, the 8 domains of practice. And there are core questions that we ask of everybody, as well as clinician role-specific questions, for example, for nurses or therapists or social workers. And we also have caregiver-specific items in the patient and caregiver instrument. We also ask about demographics and preferred communication methods, information sources, and location of palliative care services at the end of these questionnaires. And for the clinicians, we also ask about palliative care training experiences. Next slide, please. So on the left is an example of some of the clinician knowledge questions. And on the right are some examples of some of the patient and caregiver attitude questions. So an example of one of the knowledge questions for clinicians that we included is palliative care should only be provided for patients who have no curative treatments available. And that is a true, false question. And one of the attitude questions for patients and caregivers is, palliative care relieves pain and other symptoms. And that is on a 5-point Likert scale from strongly agree to strongly disagree. And we didn't include the confidence section here, but one of the confidence questions for clinicians is, I feel confident managing palliative care emergencies such as severe delirium, psychosis-related agitation, and pain crises. And that, again, is on a 5-point Likert scale from strongly agree to strongly disagree. Next slide, please. So in order to further refine our instruments before piloting, we will be conducting cognitive interviews with 10 home healthcare clinicians and 10 home healthcare patients and caregivers from the Visiting Nurse Service of New York. And we will ask them to complete the survey prior to the interview and mark any items that were unclear. And during the interviews, we will go through the instrument item by item. And ask each participant to think out loud about the question using probes to understand comprehension and confidence in their answer, recall, and specificity. And then our final step will be to pilot test the instruments with 30 home healthcare clinicians and 30 home health patients and caregivers, again from VNS-NY. We will identify a sample of patients with serious illness and recruit the patients and their respective caregivers to participate in the pilot study. And clinicians will be recruited at team meetings or via emails. And we will ask all participants to complete the survey twice, and that will be 2 weeks apart. And survey data collection will occur in REDCap, as you can see the example on the right of what it will look like. And we will then conduct psychometric testing to evaluate the validity and reliability of the questions. So now I'll pass it to Dr. Shang to finish up.
Okay, thank you, Dr. Chastain. So I'm going to move, next slide, please. So, so the instrument we are develop will be the first home health care setting specific instrument to like for the palliative care, and we specifically measure the knowledge and attitude and confidence, and for both the clinician and also patient caregiver. And this will also be the first instrument to include all the 8 domains of the NCP guidelines. And I just want to emphasize, because our reviewed literature identify a lot of the existing instrument don't include domains such as social aspect and religion, religious aspect, and also the legal ethic aspect of the palliative care. So we are going to cover all these domains. So next step for our project is, after we finish the pilot testing of the both instrument, we plan to conduct a large study to measure the clinician and the patient and caregivers, their knowledge and attitude and confidence at VNS-NY. So that is our next step for. And hopefully, after the instrument was successfully tested, we hope these 2 instruments can also be adapted to different culture and different country. So that is the long-term goal for this study. Okay, next slide, please. So I want to acknowledge the funding sources. So we are lucky to be funded by the Columbia School of Nursing Intramural Pilot Award. And Dr. Murali is also funded through Dr. Stone's T32. So next slide, please. So now we still have about 30 minutes left. I want to use this opportunity to ask audience, like we have to get feedback from you to further help us to like refine this instrument. So the first question we have is, in your own experience, what are the major misconceptions about palliative care from both clinicians and patient caregivers that you have encountered? And how do you think this misconception will apply to the palliative care delivery in the home or community-based settings? You can either speak or you can type through the chat.
Well, I would think a lot of it is that people think that it's end of life care and giving up. And that's a misconception. You know, that palliative care is an end of life care.
Yeah, that is what we find from the literature review. Most of the literature we find they focus on the end of life and focus on the cancer patient. I do
that
know.
also, I'm sorry.
Yeah, go ahead, Ben.
That also is a misunderstanding. There is an understanding in certain places that palliative care is only available to patients who have serious conditions involving cancer, and that is not so. Palliative care is or should be available to patients with all serious long-term illnesses that are not cannot be cured. And I must say I agree with Pat as well that the misconceptions about palliative care are certainly that palliative care is only given at end of life, and there is confusion between palliative and hospice care. So those terms need to be clearly defined.
Hi, hello.
Yes, go ahead.
In my own experience, I visit patient in the, at home in this neighborhood. They believe once patient is on palliative care or hospice care, which they mix up all the time, we're going to kill them with morphine. And they don't want that. And after I've been listening to this, I see the home health aid were not included in the studies before. They play a very important role in the patient's care and life. Sometimes you deal more with the home health aid than the family member. The family member might live in out of state completely, and what you have on to deal with is the home health aid. They are the caregiver, they are the healthcare proxy, they are sometimes paid family member that are paid to the CDPAP to care for those patients. They need to be educated. They need to know the difference. They need to know what is the difference between pain and discomfort. Sometimes they will tell me, no, she's not in pain. When I ask her if she's in pain or he's in pain, they say no. But when you go there, you can totally see that they are they're not comfortable. They have discomfort. So they need to know the difference between pain and discomfort. Another thing that I put down is they're talking about the ethical and legal issues with palliative care. I'm not sure about what to make out of that. What are the ethical and legal issues with pal care? That will be my question to the presenters or to the audience.
Right. So we have a couple of question items in our survey. Specifically asked of the healthcare proxy when the patient cannot make are not cognitive capable to make the healthcare decision, mm-hmm. and the healthcare proxy, what their responsibility, something like that. And actually, maybe you can share with us the specific question we have, and Bridget, you can stop sharing and let Ashley to share the screen. So we do have some specific question for that. Yeah, that is very very important. We do not find any literature specific targeted nursing aids regarding the palliative care, but there's a large workforce in the home health care industry, and unfortunately, our current instrument have not. Maybe we need to think about include nursing aids in our the future test as well. So these are the question items, and that I think is it this clinician instrument or?
Yeah, this is for clinicians.
So do we have a specific question in for the decision making surrogate, and we also have some question regarding for the patient and the caregiver.
Sure, I can show that as well.
Mhm. And we also have a question like related to the patient's religious and culture aspect, how to ask how this their culture, belief, or religion will affect their decision making. Okay, so this
Jingjing, on the last one about the most, you might want to reword that question so you don't say a most form is a form.
Okay.
Using the word form twice in a sentence.
Okay, thank you. We'll do that.
Thanks, Pat.
Also, advanced directives are actually living wills and healthcare power of attorney or healthcare proxies. Most are medical orders.
Okay, thank you, Carol.
Sure.
So this is the question item we have for the patient and the caregiver. So this just like some items we have here. Maybe we can share a few items here, and then we can get feedback from the audience. Okay.
I think we have a question or comment from Dan. Where did he go?
Hi.
Okay.
Nice project. I really liked, Komal, your review. I like the idea of assessing, the needs and trying to get especially home health aides involved. I think that within the field of palliative care, to address your question, there's challenges right now about what is palliative care and where is it most effectively deployed and who gets it and who doesn't. And so on one side of the spectrum, you have people who are like, palliative care, isn't that hospice? And you scream from the top of your lungs, no, let me tell you about palliative care. But on the other side, there's primary palliative care providers who are palliative care specialists who are like, we can only go so far. These are the people that we will see. These are the people that we won't. And even within the field, the other difficulty is advanced care planning a true core component of palliative care, or is it something that's distracting away from case management and symptom management? So when you're asking about questions about what are some difficulties or barriers, those are some things that I thought of. I'm of the proponent. I'm actually a fan of the sort of work that you're doing. I think it's going to expand the way that we look at palliative care and try to bring it in the community setting in a way that's really important. I guess my question is, once you develop this tool, what's its implications? What are you going to do with it? And how are you going to sell it in order to change palliative care within the community so that you can embrace community-based palliative care that's probably at a generalist level rather than a specialist level? So I'll take thanks for answering my question.
Thank you, Dan. Thank you very much. That is a great question. So the purpose for us to develop these two instruments, we want to assess the current the knowledge of what the perception of palliative care in the home health care industry, because there's a hope the palliative care will be widely employed in this industry, and we want to make sure the clinician is ready. If we identify any need for education, we can design the education module to improve their knowledge and attitude. So that is the one of the purpose. Another thing is we want to know how readiness are the public to accept the palliative care. As the most of the our audience shared, there's currently misunderstanding about palliative care and hospice care. So we want to know exactly how much do the public know about the palliative care, and also hopefully in the future we can design some intervention to improve the knowledge of the palliative care. So
if I could just ask a follow-up question.
Mm-hmm.
So that's great, right? We don't have a good way of measuring this. You develop it. you find out that there's deficiency in maybe in VNS New York, although they're pretty good, and then you're like, look, as an organization, you have this deficit. We can offer you this educational opportunity that can enhance their knowledge. But then what? Is there a gap of people that is just that palliative care isn't being deployed enough in this setting? Or is it, how are you going to redesign care by getting a better assessment of what people know? So sorry to interrupt, but I find your answer compelling. Thank you.
No, that is very good suggestion. We have nothing that, how can we, I guess there's multiple aspects will be involved to push healthcare in the home healthcare setting and community settings. I think one way is to get more reimbursement from the Medicare, from the Medicare reimbursement benefit. So that is something, the leader of the home healthcare industry will push on this. Certainly from the VSNY, we've been tested. And we will share the results with the VSNY's, the leadership, and hopefully we will make some improvement, change. Maybe.
So Jingjing, would it be fair to say that based on what you find, your results could maybe say, okay, we need to really educate our palliative care team. VNSY has a palliative care team. We need to really educate the palliative care team more, or that it's, and so if another visiting nurse, other home health agencies would need to really specify a very, almost specialist palliative care team within their team, or get those services somewhere else. Or you come up with an educational program for them. Is that where you see this might go, or to say everybody's got a pretty good knowledge of it, which somehow I don't think. But that's how I can see the results, maybe informing something down the line.
Yeah,
go ahead.
Make a comment? Hi, everybody. Margaret McDonald. I'm from the Visiting Nurse Service of New York and a collaborator on this project. So I just want to separate a couple of things. So this particular initiative will really focus on the instrument development, and we won't have, with the sample size, a whole lot to be able to walk away and say whether about the specific findings, because that's going to be the next iteration. But Dan, I think to your point anyway, there's a huge push by associations and palliative care associations to integrate palliative care in home health. There's no additional reimbursement being offered. There's no so within the episodic payments of home health, which are limited, it's just there's a push to saying these are going to be the expanded services without necessarily coinciding reimbursement policies. So that is a separate issue altogether, but part of that, this will advance a little bit of the discussion, because we are saying, okay, if you're pushing to say it's going to be included and it's going to be in the generalist workforce in home health, how prepared are the generalist home nurses and therapists and social workers ready to provide these services versus a specialty palliative care workforce, because that's what's being suggested. And it's just okay. And so it is to say, what's the baseline? Where do we go from here? And if it's going to be integrated, it's going to say, this is the effort that's going to be needed to prepare the workforce eventually. And it's not going to be just at the VNSNY. The hope is the next iteration of this after we do it is to survey many more agencies besides our own.
Yeah, thank you, Margaret.
I'd like to interject if possible. So actually, Margaret, I don't think we've ever met. I worked for VNSNY for many years. I was part of the AIM grant project that was from years ago. And actually, as a nurse practitioner, my responsibility was to teach frontline CHA nurses how to perform, a palliative care. And so it only lasted for a year and a half, and I have no idea if those nurses are still employed by VNS or have moved on. But there was an effort, and it was based on the Sutter Home Care AIM project of teaching frontline nurses how to, primary palliative care. And VNS has been very supportive of palliative care for a really long time. So I just want, there are nurses, we have done this before. I've also been a nurse practitioner in palliative care in outpatient settings for many years. And I just wanted to refer back to the question that was asked a while back, that there are concerns about, whether patients and families understand what palliative care is. If you tell them it's supportive care, it's an extra layer of support, everybody wants it. Where the barriers occur are with healthcare providers who don't understand what palliative care is and are afraid that they're going to lose control of what happens with their patient. That's just been my experience. Thank you.
Thank you, Carol. I saw Marie has one comment regarding the instruments we have here. Actually, that is one of our
the length of our
the length of our survey.
We completely agree. It's too long.
we're very worried about that too.
Yeah. So because they are all very great items, we want to keep them, but we also aware about the length of the survey.
So I would say between the two steps of the cognitive interviews, we'll hopefully eliminate some of them. And then also when we do pilot test and look at the distributions and skewness of the data, that will help us with some item reduction. But absolutely, we are not going to launch an 114 question survey. This was just, we haven't taken the courage to eliminate more ourselves yet. So we're going to need input from others and looking at the data from some volunteers to help us.
Yeah, and
well,
also
maybe there's some volunteers here that might want to look at the data and look at the survey.
Well, we don't have the data yet.
Yeah, not the data. Look at the survey. If there's any experts that want, is that okay?
Yeah, I think since we have the email list here, so we plan to send out because our online survey link is not established yet. So we want to, once we have it set up, we can send out the online survey to everyone, and hopefully we can do some testing from our audience. And in addition during our instrument development process, we ask our expert a panel to rate each items the level of priority. So we're trying to use that process to eliminate some of the less significant, less important items. But still, most of items are rated very high priority. So
it was really tough to compare back. Coming from home care, palliative care researchers at Mount Sinai, feedback from clinicians, palliative care clinicians, it was really tough to pare down, but we definitely will between pilot testing and cognitive testing and pilot testing.
Yeah, we also appreciated the very important comment Jung and John provide to us, because we need to keep the language at the literacy level at the same for the patient and the caregiver, to keep the language simple. So
right.
There's a lot of help. So another question we have for the audience is what do you identify from your own either clinical practice or your own experience, the major barrier regarding palliative care from both clinician and patient caregiver? I think some of you already shared. And what do you think this barrier will apply to the palliative care delivery in the home and community-based?
Any other barriers that people want to put in the chat or talk about?
I think for me, again, I would say the culture of the patient population, specific culture, they don't accept, they don't want to hear palliative care or no hospice care. They just don't want to hear the words. Probably based on their religion, but some specific culture, they just don't want it. They just don't want to hear it. They're not open to that conversation at all. And that's a big barrier for me.
Yeah, that's very important. And then for my own personal experience, I know one of my close friends, her mom died from the end of age of lung cancer. And when we talk about the possibility of the hospice, and she was very reluctant to accept that, even though she is in the healthcare field. She feels like she is giving up her mom. So I totally agree. This is the culture, certain culture has an important, significant impact on the delivery. Okay, and the DAME also have a comment is overlap between the standard care and palliative care. Okay, mistrust of providers, where the patient are afraid of losing independence. Can you comment it on the second, mistrust of provider, where the patient afraid of losing the independence?
Sure. A lot of people that have serious illness are also older adults, and there's multiple geriatric issues based around autonomy that come into play when they select their care. Palliative care is this great service, and it's supposed to be a supportive service. But especially if I'm a white provider that's coming into a situation where somebody is a person of color, there's suspicion there, and especially comes down to issues where you're talking about giving extra support to deal with symptoms, and the more people sometimes you bring in, the more people are fearful of losing control over their own care and their own living environment. So I do work in a Medicaid funded assisted living, and building that trust is a process. It would be great if you could just offer a service and then people would accept it. But I think that palliative care is less familiar to people. They are suspicious. Knowledge is one thing, but there's also other elements of just getting older and being concerned of losing control that I find comes into challenges when talking to people about serious illness and palliative care.
Thank you. Thank you very much. That's very important. Okay. Anyone else has comment?
Hi, Jingjing.
Hi, May.
How are you? I think that the one thing that I was sort of struck by, which is, I guess, sort of a barrier or just something that's important to know, is that I imagine, and I think you're going to do this, but I think that, we all have our own concept of what we think palliative care is. But I think because palliative care has been so focused on like an inpatient setting, that, what you can see and what the sort of symptomatology, what is going to be required, and sort of like what the needs are, meaning like what are they going to be asked, what are we going to be asking, the nurses who are going to be doing this. I don't, in some ways, I just sort of think that, there's a pretty wide gap, I think, between what outpatient palliative care is asked to do and what inpatient palliative care is asked to do, right? And I think that even more so, there's going to be a gap between community-based palliative care and outpatient palliative care. So I just think paying like really close attention to understanding that because this is going to be a different point in people's disease trajectory, because it's a different setting, and that we don't really know all that much about, unfortunately, that like sort of picking up on that nuance and making sure that there's enough attention paid, that we're not necessarily overly reliant on our existing models of palliative care to understand what palliative care would look like in this community setting.
Yeah, that's very true. That's also the reason why we want to develop these setting specific items. Yeah. Betsy, yes.
Yeah, thank you. Really an interesting discussion. I was thinking about how this isn't one size fits all, you know, and I think that's where it's been going with thinking about the different cultures that presenting it in a culturally acceptable way to have palliative care. I brought this up to you and Pat before about when I lived in the South in Atlanta. It was really not going to work for some of them, the people with whom I worked or the students, to even discuss having their wives or their mothers go into palliative care. But on the other hand, there's other people who I know a family that really appreciated guidelines coming out regarding treatment best practice for patients near end of life. Like, do you really give antibiotics to, you know, treat that infection, whatever. And, you know, found it very helpful to have a body of experts make that suggestion that no, you know, at the end of life, maybe you just do comfort and don't give anything to fight the infection. So I think people are just different. You know, some people want to be affirmed that giving this care is not necessary in a loving family or a religious family, and other people don't want to hear about it. So is there a way to make it tailored, allow it to be uniquely follow some sort of a, like, get a sense as precision, you know, nursing intervention or sense of what a family wants in their discussion of palliative care and what they find acceptable?
Yeah, I think that's that is very important component for like future develop any like palliative care like program. Unfortunately, for this pilot project, this instrument, we have a limited item to assess how their the culture, belief, or any like social aspect will affect the patient and caregivers palliative care the acceptance. But we are thinking about going forward for the future project. We probably can interview these patients from different like ethnic background and cultural background to understand exactly what is preventing them from like accept or palliative care. Another thing I want to say from our instrument development is we find a lot of existing the instrument, the focus on the end of life care, and so probably there's a patient. There's current literature found the patients still have a misunderstanding. When you accept palliative care, you kind of give up the current treatment. So that is the misconception we saw from the literature. So in this instrument, in our instrument instrument, we put knowledge in the beginning, and we want to assess their current knowledge. And after that, we're going to we're going to give a brief description in like education about what is the palliative care truly is. And then after that, we want to ask, how do you already know the palliative care and assess their attitude toward the service. So that is the process. We're trying to capture the best of the knowledge of the among the public. And Pat has a comment. Yeah, so that's very true. The essence of the palliative care is congruous with the care preference.
Yeah, so I think to me that's part of it. You know, is assessing what the preferences are for palliative care. Any last comments or anything? I personally want to thank you. It's been
Carol,
really delightful to have a discussion. What's that?
Carol had something, I think.
Oh, Carol, please, go ahead, Carol.
Yeah, sorry. This is, this gets me jazzed. So I think that the biggest issue that we need to clarify for people is understanding that actually you can do disease targeted therapy in palliative care. I think that what we need to tease out is the difference between hospice and palliative care. If you know palliative care in the hospital setting, it is much different in the ambulatory care setting outside of the hospital. So oftentimes people in the hospital are on a palliative care team. In actuality, if they were in the community, they'd be on hospice. So I think that if they accepted the benefit. So I think that teasing apart those two things would be really important for people.
Thank you, Carol. Those are two really important points. When I was coming onto this project, I was like, we really just need to make sure we have items that address that there's a difference between hospice and palliative care, but there's also the likelihood that you can get palliative care and disease treatment at the same time, because there's often misconceptions surrounding those concepts. So thank you for bringing that up.
Thank you, Carol.
Well, I want to thank Ashley, Komal, and Jingjing, and it's really nice to see work and development and have using this hour, our once a month hour, to inform this work. That's exciting to me. Instead of just I love having experts give us lectures, but I also love that we, help each other and inform it. So if other people want to have work that's in progress, next year or something, and want to use this forum, we'll have one more year of this forum funded, for the next academic year. If you have something that you want to bring and get some feedback, please do. Thank you very much. Now, there's two things I want to tell you about is our next month. I think that Bevan is going to be talking about her In Needs project, I think. Okay, so this is an R21 that's in B. It has ethical and legal issues, and it's very interesting, and she'll be talking about that, so thank you. And then also I want to tell you about April 13th. We have not yet developed our flyer, I don't think, but we're going to have a workshop, and it's going to be, there's a report coming out from the National Academy of Medicine on how to, I'm going to get the title wrong, but essentially how to reimagine nursing home care. And so this report is going to be released in March, maybe like the end of March, and we're going to have a April 13th with many of the committee members on, giving us a discussion about what that report is and what its recommendations are. So two great things to come, and there's lots of things going in the chat I see that I haven't read, but I really want to thank this. I enjoyed this hour very much, and hopefully it was helpful to everybody. So thank you.